the inappropriate use of antipsychotic drugs in long-term care. She's very knowledgeable, and her video is going to be an excellent start for the workshop. Then after Nathalie, who is a nurse and who is actually working in the Eastern Townships, and she's clinical nurse and also assistant to the head nurse and interim unit head for the CISSS des Laurentides. She's also studying in a master's in nursing, and she's very knowledgeable of education towards nursing and the topic itself. And so she's going to continue on, and then after we'll see how time goes so that we have enough time for discussion and question on the specific issue. And I'm sure you have all a lot of questions, considering this morning we went over a few topics and we could see somewhere at the end of the corridor that we would be talking about physical and chemical restraints. So would that be a good time, Susan? Please continue if I have not completed your presentation.
Okay. So what I'd like to do is to pick up on a few of the themes that were discussed this morning. I didn't realize that I would be doing that, but coincidentally, there were things that were talked about that fit nicely with my presentation, my story. So what I wanted to do was to tell you my personal experience with respect to caring for my mother who lived with Alzheimer's disease and what actually happened with her when she went to live in a long-term care facility, a nursing home, which was privately run. And you see that each of you should have a red and a green card in front of you. I'm going to use those throughout the presentation for voting. So red means no and green means yes. So it's a very simple process that I have. And I'd just like to quickly go around the room and find out what is your background. If you just say caregiver, care worker, no need to give your name, just so that we know who's in the audience. Anne, why don't you start?
I'm a researcher and nurse.
Researcher and nurse.
I don't mind saying my name. My husband is a resident in a long-term care facility.
Okay.
I'm a retired nurse, and I also was caregiver.
Okay.
Benoît Turcotte, Conseil pour la protection des malades.
Ah, okay.
Caregiver.
Okay.
Caregiver.
Right.
Social worker. Director of nursing.
Ah, okay.
Teacher.
A counselor working with families with Alzheimer's.
Who?
A counselor working with families with Alzheimer's.
Okay.
I'm a student at Banyan Special Care Counseling.
Also, okay, great. So we have a mixture of care partners, care workers, educators, etc. So what I'm going to do is, again, tell you a little bit about the story of my mom. I was living overseas, and my mom got Alzheimer's disease. And I came back to take care of her in 2011. And I lived with her for a year in her own home. After which, she was placed in a long-term care facility. Now, when I came back, I knew nothing about Alzheimer's disease. I knew nothing about dementia. I'd never been a caregiver. I don't even have children. So I had no experience at all. And I was, as many caregivers also don't have any experience, and they're drafted into this role. So I began at ground zero. And I'm hoping that I'm going to click on this and it's going to change. So this is my mom. And I'd like to ask you, this is she and I on a walk in 2009. Now, based on what you see in the picture, what kind of woman would you describe my mother as being? Anyone can shout out anything anytime.
Active.
Active.
Fun-loving.
Fun-loving.
Enthusiastic.
Enthusiastic. Happy.
Fun-loving.
Fun-loving. That pretty well captures it in a nutshell. So she was a very active person. She loved sports. She was always on the go. She was a real estate agent. She was running around all the time. Her favorite expression was, "We've got to get going. Let's get organized." So what happened was on November 16th, 2012, she went into a long-term care facility and nursing home. And what happened was, within a very short period of time, she was medicated, she was physically restrained, her whole life basically changed. Her character wasn't allowed to, she wasn't allowed to be herself. And so what happened, I became very much an advocate for her, and I learned a lot during the time that she was in this long-term care facility. So what I would like to do is to share with you a little bit how my mind changed and ask you some questions about behaviors. First of all, I created two surveys with about 30 questions on the surveys to try to help people to understand why people with dementia, Alzheimer's disease behave as they do. And I'm going to share some of those questions with you right now. First of all, if you were confined in a place that you didn't want to be, if somebody put you somewhere against your will, would you try to escape? Using your cards, answer green for yes and red for no. Would you try to escape? Right, so 100% of you, est-ce que vous parlez anglais?
Pas beaucoup.
Parce qu'on a un atelier aussi en français cet après-midi.
Mon Dieu, quel numéro?
À 2h30.
Pardon? À côté?
Il sera.
Ça va être plus facile pour moi, oui.
Oui.
Monsieur,
Ben, ils m'ont fait
monsieur, l'atelier numéro 4, il se donne en français à 2h30.
Alors, à 2h30,
La même chose.
vous allez maintenant, présentement, atelier 2.
Atelier 2, il était en français, mais
C'est pas le même, mais ça sera.
parce que
Okay,
Isabelle était l'inverse que nous autres.
Ah, merci.
okay, so 100% of you answered, yes, I would try to escape. So what I did with my survey, I put it online, and I had 1,600 people respond to my survey of 30 questions. And guess what? 96% of them answered exactly the same way as you did. And of those, 98% of the respondents said they did not have dementia.
Who are the 4%?
Some people said they didn't know or they wouldn't want to. Okay? So clearly, it doesn't matter if you have dementia or not. If you're held against your will, you're going to want to get out. So the next question I asked is, well, okay, if you want to get out, how many hours or days will pass before you feel like you want to get out? I've got a scale here. So the scale is, would you want to get out after 1 hour, 12 hours, 1 day, 2 days, 3 days, 4 days? So I'm going to ask you, if you wanted to get out after 1 hour in your house, put up your green card and keep it up. Okay, 1 hour. After 12 hours in your house, would you want to get out? Okay. After 1 day, would you want to get out? Okay. After 2 days. Okay, so I'm trying to build, you see? How long would you be comfortable staying in your house without being able to get out? This is the responses that I got from people. So 15% after 12 hours, 25% after 1 day, etc. So about 80% of people, after 3 days, they're getting very agitated. They want to leave. And yet, what we do is we put people with Alzheimer's disease in a place and we keep them there, not being allowed to get out for months at a time. It's hardly surprising that those people become agitated. What would you do? So then I asked people, would you feel agitated? Yes? After not being able to get out? And in fact, that's exactly what my survey respondents answered. Sorry, I've got mixed English and French slides, but they said 90% of them said, yes, if I was forced to stay in a place against my will, I would become agitated. Oh, sorry. I asked them, in addition to getting out, if you were forced to sit.
C'est pour la télé.
Oh, pour la télé. If you were forced to sit in your chair for a long period of time without anything to do, would you become agitated? Green or red? Okay, so almost 100% of you would become agitated if you were forced to sit for a long period of time. Then I asked myself, okay, how long is a long period of time? Is it, oh, how do I go back? Can't go back. So is it 0 to 9 minutes? For you guys, is it 0 to, how long would it take before you became agitated? Less than 10 minutes? Any greens? No. Between 10 and 20 minutes? You leave your hands up. Between 20 and 30 minutes? Between 30 and 39 minutes? Okay, almost everybody before 40 minutes would become agitated. 80% of people would, if forced to sit down for more than 30 minutes, would become agitated. But what do we do with our people who have Alzheimer's disease? So the definition of a physical restraint is any manual method or any physical or mechanical device, material or equipment attached or adjacent to the person's body that the person cannot remove easily and that restricts the person's freedom of movement or normal access to his or her body. It is the effect of the device on the person that classifies it as a restraint. So you don't have to have a belt around you to be physically restrained. I'm going to show you an example of my mom. This is a video, and hopefully Anthony's going to play it for me. It's very short. When this video was taken in 2014, my mom was perfectly capable of walking. But she was put in a wheelchair and told every time you see the little, this little blue box here, it's one of those pads that when you stand up, the alarm goes off, and then somebody tells you, a nurse or a care worker, they told to my mother, you're not allowed to get up. You're not allowed to get up. So that is a form of physical restraint. It's not a belt, but my mother was restrained in that wheelchair. Then when she tried to get up, well, this is another kind of physical restraint. So after a while, she kept trying to get up. She still could walk at this point. And to give you another example of a physical restraint, you know, people come in, visitors come into the home, and they see people in these nice recliners. And they say, oh, isn't that lovely? She's so comfortable in that recliner. But my mom didn't want to be in a recliner. And this is what she tried to do. Oh, sorry. Can you play the video, Anthony? Or il est pas là? Just click on the video. Click on it. Click on the video. Yeah. Works. Oh, it came on the side.
Oh, I was wondering. Well,
It came on the side. We don't know how to fix it.
what's wrong? What are you trying to do?
Can you try the other one?
Trying to get out of here.
Okay, there, that'll do. It came on the side, the first one. So that's my mom trying to get out of the chair. Est-ce que tu peux jouer l'autre avant? De le mettre, oui.
Okay, I'm going to help you, okay?
No, but can you put it de l'autre façon parce qu'il est tourné? Okay. Anyways, you get the idea, right? The recliner is a physical restraint.
Because of the angle?
No, the video's turned on its side.
No, but the
Yeah,
recliner
so-
because of the angle.
Yeah,
You can't get up because physically you can't.
right. Well, it's a physical restraint because it's not allowing her to do what she wants to do with her body. She's not chemically restrained. She's 85, 86. But she was totally capable of walking. But her stomach muscles were not strong enough to pull herself up so that she could get out of the chair. Combien de minutes? 5 minutes? Okay. And what they would also do was to put underneath, when she had been strong enough, they would put a chair underneath the bottom part of the recliner so that there was no way for the recliner foot to go down. That's again a physical restraint. She was also chemically restrained with antipsychotic drugs, and this is what she looked like when she was on the medications. Anthony, can you play the first, tu peux jouer la vidéo? So that's a video, not a still photograph. That's a video playing on the left. Anthony, can you play the video on the right, please?
Patty.
Ça, c'est moi, je lui dis Patty.
Patty. Patty.
So she was completely in a catatonic state. And she was like that for 4 hours every day. First thing in the morning, she got quetiapine and risperidone, and it put her in that condition. When she was not medicated, so this is physical and chemical restraint, because they would wheel her up to the dinner table and put the wheelchair close to the table and lock the wheels. So she couldn't even, she used to scoot around in the wheelchair with her feet, but she couldn't even do that because she was pushed up against the table, and you can see that she's asleep. She was also chemically restrained, both restraints, chemical and physical. So there's my mom in August 2009 on the left. There she is on November 16th, 2012. And that's her medicated and chemically restrained in October 2015. I'm going to show now a video from, we may not hear the sound, but it's her singing 2 months after this. And after the drugs have worn off, you're going to see how animated she is. Oops, sorry. Anthony?
The moon shines over the cowshed. I'll be waiting at the kitchen door.
You like that one, eh, Mom?
Yeah, well, that's funny.
It is funny.
So she was perfectly able to sing and smile and understand after the drugs had worn off, or on some days she spit out the drugs. And I could always tell when she'd spit them out because she was like alive. Whereas the chemical restraints and the physical restraints robbed her of everything that she was able to do. So what I would like to see is that we stop giving people antipsychotic drugs and we stop restraining them, and we do the kinds of things that Nicole Poirier was talking about this morning with Carpe Diem, and putting the person first and letting them live and engaging them with life and providing them with opportunities to be people instead of turning them into zombies.
Thank you so much, Susan, for this entrée en matière and this example that is obviously leading us to a need for respect of dignity of the person. And you gave us the best example we could ever have, I believe. Now let's see the point of view of the practical practitioner and the nurse and see how it has come that we do have impose at times physical and chemical restraints.
Hello, everybody. After a video like this and a presentation like this, of course, it brings you questions. Yes?
Can you use the
microphone.
microphone?
Oh, sure.
I hear the lady next to me more than you.
Oh, okay. Hello? That's better? Okay. After this presentation, it brings questions. Why does this happen? How come in a long-term care facilities or any facilities you see this kind of result on a human being? And I work in a long-term care facilities for many years, and I've seen things, and I've been involved in different things, and I have also a point of view of a team. You know, we work together with physical therapists, occupational therapists. We have somebody working for even the spiritual care will be part of our team with our préposé and the auxiliary nurse, and the doctors and pharmacists. And there's a side of what's going on in the institutions that we'll have to discuss today, and we have to present you as well with this. And over the past 15 years or so, there's been a change in the use of physical restraint. You've probably heard of the government's, the law, and what we have to do as a caregiver, professional caregivers in the hospitals and even long-term care facilities, what we have to do. And there is a procedure that we need to do. We need to do a physical evaluation at admission. We need to see the risk of falls, and there is charts and things that we have to do. We work as a team on these cases. And then also, we have to remember one thing over the past years with the formation teaching of our staff is that physical restraint is the last thing that we have to use. They are there in case of emergency, and there is very rules and laws to follow about that. But often they are put on somebody, and you have to question why. We have alternative method, and one of them that was presented in the video is the beeper, you know, the one sitting on a chair. And in our facilities, this is considered an alternative method, but we're talking about somebody who has high risk of falls. And this is sometimes what's missing in the institution is that families and the resident don't have the explanation. They don't understand why you would use, something like this that will beep, and why would your mom sit in a chair. But I think often is we're missing the information. We don't explain why we're doing such things. And in many cases, it does help. And usually if somebody gets up, and that's why I'm trying to explain to you what those alternative methods are. Usually they're not there to have somebody sitting in the chair. They are there to tell the staff, this lady got up, now check her, she's at risk of falls. And often things are not used properly, because in your case, this is what you present is that she has to sit in the chair, but if you use the alternative method properly, they are there to give us a warning, to prevent a fall. So you see a very different perspective of the use of the same machine, the same device, to help us in a way to stop somebody from falling, but allow them to get up, and also to just keep them in a chair so they don't get up. So there's a very different point of view, and the way we use things is supposed to be, there's design, there's ways to use them that are safe, and they are there to prevent falls. But they're not supposed to be used for somebody to sit in a chair. The same thing is you have belt now that are with Velcro, and a resident can have this belt on, and when they pull on the belt will ring. It will give the caregiver time to get there, make sure that the person will get up safely, and bring them to a bathroom or to answer their needs. But of course, if you put that belt that is not, that can be open easily, but if you put it on somebody that has no intention of putting it open, or somebody that doesn't even move, why are you putting that belt? This is the first question you always have to ask yourself. Why are we using alternative method in a wrong way? Also, there is an experience, and we have to talk about this. When we work in the long-term care facilities, we're faced with people that will have a behavior problem considered by either the staff or the other residents or the families. Somebody can hit somebody else. You've probably heard of that, you know, a resident that will punch somebody else in the face. What is a team supposed to do with that? And we do have procedure, and we have to evaluate the needs and what's happening, because this is difficult for a family that is a witness and that their own parents get hit, but also for the family and the resident that did the action. Because one is a victim, the other one becomes the aggressor. And the staff, we have to work on changing this vision, and we have to act on the perception of the situation for these people. Often when you have situation like that, aggressive behavior, you see the chemical restraint use. And this is another issue. And this is where it gets very tricky, because right now in Quebec, we don't have a very clear understanding of what is a chemical restraint. We don't have an understanding of we don't have the government agreeing with the doctors of what is the definition of a chemical restraint. So it becomes very hard to have protocol and procedure to have the chemical restraint put in and then try to reduce them like we do with physical restraint. So you have this very gray zone in the literature and in our practice. So it depends on many factors. Some doctors are really proactive on medication, but they will have no physical restraint in an establishment. Other doctors will totally change their point of view, and they will tell the team, look for other options first. And this is what we are trained to do now. We're trained to look for other options. Before there's medication, before there's a physical restraint, we have to understand what's happening. What is causing that behavior? And this is still in research, and there's still a lot of things going on with this, and we're still learning a lot. But there's different approach taught to our staff, and some does very well. You heard some example this morning of how just by doing a right approach you avoid medication, but there's still a lot to do in that case. There's also the ethical issue of the rights of one versus the right of the other. I talked earlier about the victim versus the aggressor. Our goal is to never have that situation happening, but for the staff and the doctors, there's a very big ethical battle. Do you give medication to somebody that's hitting the others, or you try to change the environment? We try different things, but still there's a lot of questions to rise with these issues. At this point right now, in what's going on is we still have to do a lot of formation. A lot of staff have to learn more. They have to be put in front of situation like today, and think about things differently. Doctors are slowly changing also their vision of what's going on, but there's still a lot to do.
Can we?
You would like to intervene right away?
Yes, I would right now. Frankly,
yes, why not?
I do not like anything you said.
Okay.
Okay? Having a husband who went in totally capable of going to the washroom on his own, totally capable of walking, being called a wanderer because he's forced to bed, trying to medicate him to get him to go to sleep when this man in 51 years never went to bed till midnight. You cannot do that, and medication is not acceptable. What you're saying is totally unacceptable. I'm sorry, I'm living it.
I'm sorry, ma'am. Did I say that medication was acceptable?
You're saying that it should never be given. In Ontario, there are places, my son is a doctor there, it's totally forbidden to give antipsychotic drugs to anyone with memory issues. In my husband's floor, 86% are on antipsychotic drugs. It's wrong, it's inappropriate. The residents are like, And that's what they want,
And-
diapers, comatose situation. And what you just said is actually giving them the right to do this.
I think
I'm
it's,
sorry.
yes,
That's
I,
how I read it.
very important that you do raise this issue and you raised your concern with us. This is what the workshop is about. And the question we have for this workshop is, are these restraints, physical or chemical, adapted? Are they respectful of the needs, and I should say of the capacities of residents in the long-term care? Now, the point of view here is a point of view of a practitioner who is also abiding by the rules and by the recommendations and by the protocols. But we appreciate greatly your input with your experience. It's very important. I think maybe the group will also want to react. Maybe we should take 5 to 10 minutes to go over the essential rules that are basing the legality of what Madame Houle has just mentioned to us, because it's annoying, and I can certainly be very agreeing with your reaction. I myself, I'm a lawyer, practicing for defending patients' rights. The last time I went to see one of my clients at Hôpital Jean Talon, I had talked to her the day before, and when I visited her, she was tied up in her bed, 4 members, and she could not talk. Then I went over the next day, and then she could talk. But she was like in sort of a semi-coma because she was restrained physically and chemically. In the long-term care institutions that we have, the residences we have, there are possibilities for practitioners to prescribe. I would like to see on the screen Antoine, Alex, whoever is en arrière, si vous mettre ma présentation. So we'll see that it is legal to facing this situation. It's been adopted 20 years ago. Est-ce que j'ai la possibilité d'avoir le... Merci. And excuse my English, I'm trying my best. So what's up next is this?
It's the middle one.
The big...
The big button in the middle there on the top.
Okay.
Voila.
So 20 years ago, let me just take my time. 20 years ago, we had this specific article in the law that was adopted permitting the imposition of an exceptional measure, which is restraints, chemical and physical. I'll get to the section then after. The presentation is in French mainly, but I will be articulating it in English. Then after, in 1999, the Collège des médecins du Québec issued recommendations because it's this possibility of prescribing restraints is a medical prescription. So the doctors are involved into this, and they are the ones who prescribe the exceptional measure. In 2002, the Minister of Health issued orientations, and you can look them up. These are all accessible on the net. These recommendations essentially are oriented to explain and express how these should be developed and on the ward. There are 6 principles we will see in a minute. In 2006, there was a first, so 10 years after this law was enacted, they put up a programme de formation. The programme de formation is actually was reviewed in 2011, showing up that there was a need to improve and improve the conditions and improve the practice on the ward, on the unit, in the residence, in order to reduce the use of restraints. Okay. In 2008, that is already 10 years ago. See, things are are changing very slowly in the healthcare system. You saw it this morning in Quebec, possibly, but I mean, I've been knowing the health system for 40 years. I've been practicing for 30 years. Things are slowly changing, and it's probably a good thing that we get more involved and more interested and more knowledgeable of all of these rights and also in, these like regulations. The programme de formation that was set up in 2008, Nathalie didn't discuss about, but she does use it to teach to her nurses. And it's extremely interesting to see that they are looking for alternatives to restraints, real alternatives. The bath issue, the example that was given this morning, that there was an opposition to the bath, there is a list of, I think, 24 possibilities to avoid the reaction of aggressivity and to bring the person to be washed, period. So it is very good. The cadre de référence that was given at the very beginning when in 2011, when after institution of the orientation ministérielle, is also the cadre within which professionals have to work. So the nurses have to expand on this cadre. They have to elaborate their procedure, which is called protocole in French. But there are still very big problems. The rapport des protecteurs du citoyen, le protecteur du citoyen, I don't know if we say the citoyen report, protector in English, the ombudsman, okay? He does resort some situations that are extremely annoying, and I'll give you a few examples later. Fortunately, in 2017, that is last December 2017, there was a report issued by l'Institut National d'Excellence en Services de Santé, okay, INESS. Issues an extensive report having reviewed lots of studies, many studies and all literature relating to chemical restraints in the long-term care. And it's, I will not give you the whole story of it, but I'm going to sort out a couple of recommendations, the conclusion they came to. This study was meant to reduce chemical use. Now, this is this section 118.1, which enables practitioners to exceptionally prescribe and impose force, isolation, or mechanical means or chemical means of restraints. They shall not be used to place a person under control in an installation maintained by an institution, except to prevent the person from inflicting harm upon himself or others. So you see already the situation is that the criteria is that there is a criteria of necessity and of danger. This was adopted. This is, the rule is it may not be used to place. So that's why the rule is that it is exceptional that such a prescription be made. And we will see the specificities of this section a little bit later. The use of such means must be minimal, resorted to only exceptionally, must be appropriate, having regard to the person's physical and mental state. Nathalie was saying we have to go over, make an examination. This morning we heard we have to know about the person, get knowledgeable about the person. This this exemplifies how this section is being, in fact, made an activity. Any measure referred to must be applied in respect of a person, must be noted in detail. So that's the protocol, that's the procedure that shall be adopted. And the procedure shall be adopted. So let's move on and see the definition. I think Susan gave to you an excellent definition of restraint, which is called contention en français, and chemical substance, well, we all know it's generally antipsychotic. Les orientations ministérielles just after adoption of the law referred to first principle. It's a measure of security when there is an imminent risk of danger. It must be also in the last resort, second principle. Third principle, it should be the least restrictive, the least restrainful to the person. Fourth principle, it shall be applied in the respect and the dignity of the person and with regards to the security of the person, having to do also to comply with supervision at all times. Fifth principle, respect of protocols. And sixth principle, always follow up with an evaluation and follow up. So if we go by the theory, orientations, and cadre de référence, we would end up with having a reduction and elimination of restraints. It looks like it's difficult to come to reduction possible. Elimination seems to be extremely difficult. I gathered over the last 2 months, I've gathered statistics from the province, from the different CISSS. There are variations, but in general, there is a tendency to lower because surveillance is closer and closer, and they have to report annually. They have to report also frequently. So they have to to measure at all times how they apply the restraints. And this is the pressure being put by the necessary follow-up is thus helping the diminution in percentage of application of restraints in the long-term care residences. It's important also to privilege the alternative measures. This is in the literature everywhere. It's in the programme de formation. It's in the recommendations that have been made in the past 10 years. Everywhere it is. They're trying to find alternatives and to have nurses informed and knowledgeable and how to find alternatives. So conditions of use are strict, only exceptionally, only in last resort, and the least restrictive as possible, always following a medical prescription for a limited time. And also it must be, if it is renewed, it's going to be renewed with documented reasons. So it should be as short as possible. So we have seen prescriptions in medical records. Some of them we have seen for 2 hours, others 24 hours. It should never be for a long duration. There are alternatives to the restraints. There is a model that's been called the model Kayser-Jones. It's in the literature. This model is, for me, patient's representative, is very interesting because it puts the person at the center of the decision. It's also aiming at looking at the biopsychosocial particularities of the person. So her beliefs, her preferences, her habits, or I say her or his, right? His values. And also it's aiming at changing the environment of the person, changing it so that it's not too cold to go for a bath. There's no raised voice in putting pressure on the person. There's no confrontation. It's not going to be, this morning the question with the bat, I thought maybe she didn't want to be bathed by this person because he was a male. Could very well be. So trying to find, okay, let's put on the structure, or okay, face the structures. What are the structures here? How can we adapt, have the personnel available, knowledgeable, and know about the procedures? You have to, first of all, address why is it the situation this way for the person to react this way before coming up to this exceptional measure of restraint, and also the environment, involve the family, the proche, the friends, and the other. Take into consideration the family, the personnel, yes, and the other users. With regards to a rapport du protecteur du citoyen, I'll be very brief. In 2005, there was, you can look it up with their annual report, there were blames with regards to the way the restraints were applied. They were generous in blames. In the past years, in between 89 and 98, there were 37 persons who died because of physical restraint. We know physical restraints, the risk is, it's a treatment, it's a care, it's a treatment. Huh? So it can always, if wrongly applied, it can end up to the death of the person. And it has happened throughout the years. I didn't come up with the statistics, recent ones. The most recent ones are 21 persons in between 2002 and 2012 because of the restraints being wrongly applied and the person found dead after down beside her wheelchair or her bed. Judges have come at times to evaluate situations of death or situation of great negligence because it's unacceptable that a person dies because of the application of a physical restraint. And that's why I say everywhere we're pushing to improve and to find alternatives because this is not acceptable that a person dies because of wrongly applied physical restraints. So judges have come at times. Fortunately, there's not too many decisions being rendered in this field. Let me talk to you because I really want to have a discussion with the group. Antipsychotic. Why is it that we came up with this study of the l'Institut National d'Excellence? Because we have to name him, Monsieur le Ministre Barrette de la Santé provoked it last year. Why did he provoke? Probably there was something in the news that there were many falls in the long-term care institutions while there shouldn't be so many falls. And we put our finger on the fact that it could be due to the surmédicalisation. How would you say that, Susan? Over-medication, thank you, over-medication. And so he said, okay, we need to reduce for half of it the antipsychotic dosage. So that's how we ended up with this study of l'Institut National, who was looking at what is the optimal usage of antipsychotic for people who have thus been diagnosed with what we call nowadays. We don't say dementia anymore. We don't talk about. We talk less and less about Alzheimer's disease. We talk more and more about les troubles neurologiques neurocognitifs. So neurological. Major neurocognitive disorders. So you're going to see this abbreviation at times. And you're going to see also the perspective, in fact, is that there are symptoms that we diagnose with people who are going through these neurocognitive impairments. And the approach from the milieu is to identify the symptoms and prescribe. If the measure is exceptional and it's available, maybe one will end up with a prescription of restraints, chemical or physical. The perspective from the patient's point of view is find alternatives before you tie me up on my chair, before you tie me up in my bed. But what is of interest here, and it's the last slide, recommendations from the INES have come to the conclusion that from the best clinical practice, is that how we say this? The best clinical practice, and the members of the committee they have consulted, is that we're all in favor of stopping deprescription of antipsychotics with persons who have major neurocognitive disease or, yes. So there is hope. Now my question to you is it possible to maintain dignity of the person? And how is it possible for families to come up to be more aware and to be more in the perspective of ensuring dignity of their loved one? How is it that we can improve even better this? How is it possible? Do we have rights as family members? Do we have rights as users? How is it possible to talk for those who cannot talk? This morning we had this video. This person could talk over the video. How about all of those who do suffer the same thing but cannot talk, but do feel like Susan's mother? So the time is for you now, and we'd have lots and lots of questions. I don't know if Susan or others want to react here. Or...
Je suis complètement pas d'accord avec vous autres. To be honest, I think that for me, ideally, if these things are happening, all the things that you say, it would be fine. But this is not the reality. It's not the reality. From my side, I didn't see this at all.
Hello, my name is James Ciampini. I'm an attorney as well, but not here in that capacity at all. My father is in a home, and he's now almost 93 years old. I understand that in extreme cases, you're going to have to apply a restraint, a physical restraint, and in a very extreme case, you'll have to apply the medical antipsychotic. My problem is not with that application. My problem is with when you're restraining my father, I know you have to restrain him because he's fallen too many times and you have to restrain him. The problem is that they're not following up with any physical help to help him walk again. Less than a year ago, he could walk on a walker. He's in a wheelchair all the time now because he has no more strength in his legs whatsoever. So this part bothers me. They say to us, oh, yeah, we have him on a schedule. He's now going to have his 2-3 times a week, at least, no, twice a day at first, at least once a day. It's not happening, period. Now we're going to see he's in a new home. But at the other home, the private home, he wasn't getting it. So, yes, I understand you have to restrain him because he'd fall. And not only when he didn't fall, they didn't like it that he could wander into other people's rooms when he had his walker. And he would leave his walker somewhere, fall. So I understand the reasons why you have to restrain him, but you cannot keep him in that chair all day long where he's complaining he has sores. And he does have. And then they have to put him Zinco or whatever it is he used to put on babies. So these are what are you doing to bring him back to quote unquote normalcy in his life? Yes, he's gonna go off. Somebody goes off a tangent. All the things you spoke of today has happened and are happening to my dad now. He's had fights. He's had a lady scream at him, hit him. They have to keep them apart. This lady thinks my father's her husband. So she's always over him. My father says, who are you? What are you doing? What do you want? He doesn't, and he can't hear well. So you're right. Every single person has to be treated as a person with separate problems from another. They all may be suffering from dementia, but their problems are separate.
Sir, what you said is so right. And this is why right now we see emerging a lot more in the health system, the idea of micro unit, smaller unit, unit that you bring people with the same kind of problems or difficulties or issues together. Even on a unit, when you have 14 together, it's a lot. It's a lot of people in the same little environment. So we're bringing, this is things that are emerging, and we're seeing the positive, but it's very hard, and you have to understand that from a family perspective, to know that your parents might change position, might change to different environment, it's very hard. And often what we see also is families don't want their parents to fall. They don't want that. So we also have this issue that comes up and that's raised, and I think we still need to teach people. And what we've done lately is I've had a group of volunteers, and we presented them with the SCPD, the approach, for behavioral problem, and for them to understand as well, it's okay that you see one of our residents in, their nightgown and their la robe de chambre, in the afternoon, because she didn't want to change, and we didn't want to force this lady to get changed. So this is also being brought up in the different centers. I cannot talk for all the long-term care facilities because I don't work everywhere, but this is things that to let you know that are raising up, and we are questioning, and we are trying to bring more information, because I think that, and we think that if you teach people, they understand better. So if you see one of our residents in their nightgown in the afternoon, it might be because she just didn't want to dress up, and sometime at home, you don't want to dress up, you stay in your nightgown, and it's okay.
Oh,
Can I
no.
ask what a micro unit is? You talked about how many people is in a micro?
There,
4 people?
there's no numbers for sure yet, because it's something that we hear that it's coming, but it's smaller. It's smaller unit, and you try to bring people with the same kind, but I don't have numbers.
Okay, because, a unit normally, where I work, for example, there was 32 people, 40 people. It's an unreasonable way, especially if you're to respect each and every individual's, not not only their own perception, but their value systems can be very different than ours. And somebody can wear a bathrobe all day because they wore a bathrobe all their life all day.
Yeah.
You know, and we have to respect that, even if it doesn't look so nice, you know, to an outside person.
What we are hearing is that it's smaller, and how many residents, it depends, we'll hear more about this in the future.
Okay.
But in les unités prothétiques, you know, you heard of those units. Usually it's 10 to 14, 15 people, sometimes 16. But in a regular CISSS, you can have up to 65 sometimes on the same floor. So it's very different issues and realities.
I have a second question, and that's this. Instead of talking about let's teach the families, I want you to know the families know that person the best. We don't. I mean, nurses don't, doctors don't, social workers don't. The family does. And quite frankly, what I would like to see, and this is my recommendation, is that the family be part of the team. In other words, the family be consulted and say, you know, what normally does my dad want, or your dad want, or your wife want, or your grandmother want, whatever. And what was their normal routine? What did they enjoy before? I'm not saying it always is the same as, you know, the disease advances, but at least you have a good idea of what that person is as an individual. And so I instead of the teaching thing, I think it's both ways. I think it's both ways. That's
okay. The teaching, it was just about the very specific how the unit works and stuff like that, about the physical or the alternative method. But for what you're saying is that there's supposed to be life stories. At an admission, a family is supposed to fill up a life story. And from this, we pick up information. And after that, families are invited to a réunion, you know, about 4 to 6 weeks after admission. And this is where, you know, there's a plan that is built from the family's perspective for the resident. It's not supposed to be about the professional's point of view. It's about the families. This is a change. Yes, I know you've had others' experience, but what I'm telling you is this is what's emerging, and you'll see changes. But it's from the family's point of view, their goal, what's possible to do, and it's a big change. But we're going step by steps, I think, depending on the milieu. I cannot talk for the other.
May I just complete on this? I think families are not enough involved. That is for sure. They don't listen. They don't recognize their expertise. They don't recognize that they can talk about the abilities and the capacities. We don't recognize families' capacities. We don't recognize the residents' capacities. We're talking about he's not capable to. He is capable of what and what and what. So this is extremely important that we recenter not only the person, but the surrenders around the person. They don't listen. We have, since 2003, introduced the participation of families into the care plan. And how many residences do work on this? Not too many. And yet, once the family raise an issue and complain, what happens? We better let them outside. We better lift the door, lift the wall, and go out. You know, disturb, and then they call the police. It's not acceptable. Families and loved ones, our loved ones need to be cared for. There's not enough people. We need to get involved. We need to get eligible. We need to talk for them, and we are entitled by the law.
I just want to say on that note, really quickly, that having had my father for 9 months in a private residence, because mostly, we're 4 siblings, but mostly because of my fear about the public system, we put him in a private system. 2 weeks ago, he was transferred to a public system, and I live with the regret of putting him in a private, because the public, where he is right now, are phenomenal.
They're asking all the questions.
Every single day I get a call, and I'm always, oh God, did he fall? Or is he being, because he only speaks Italian? The call is, oh, we had a great idea. Can we do this? What do you think of this? I'm astounded. I am astounded. Yeah, it's fantastic, but there's only maybe 25
Places.
residents there. And this is going back to micro units. It's unfortunate that there's so many waiting lists for the public system. It's so unfortunate because these micro units will possibly just create more waiting lists or accommodate specific needs.
Number of micro units.
Thank you.
Just to comment, I don't think it has anything to do with public or private. It has to do with the individual facility and the person who's running the facility. The leadership of the facility, whether it's public, private, combination, whatever, the leadership determines what the culture is, and the culture determines how people are cared for, in my opinion.
You said it before.
I'm going to direct this.
Constructive criticism.
Is it on?
We were told you could take your door. We'll release your lease for you if you like. It was not said in that rudely, but in essence, that's what was said. Well, you can leave and we won't give you any penalty. That's what was told to us. We gave a three-page constructive criticism, not just about how my dad was being dealt with, but how we were being, how everyone else was dealt with, and how sometimes no one was on the floor, and I had to intervene to stop two people from hitting each other. We're trying to guide them without pushing one or the other. They each have rights.
Yeah, I want to ask you, in the healthcare system, do they ever request not just doctors, but alternative medicines as well? Because they have an entirely different perspective, like homeopathy, reflexology, physiotherapy. We have to eliminate the classifications because every person has their own length of focus, their own focus period. I can give you a really fast anecdote. I visited with a friend of mine. I visited her mother in an institution, and the woman had dementia. And when I was with her, I would read to her, and then all of a sudden she would get a little aggressive. So I would just stop and say, do you need a rest? And we would just be quiet for 5-10 minutes. And then she would be ready to go on again.
Just if I could just add to the input of the other suggestions and commentary of the participants, and what was addressed by the panel. I think we all have common sense, and if we can touch on the question of what the definition is of a chemical restraint, just coming back to that discussion, I think. And based on, what you spoke about, the situation that had occurred with your mother, any sensible person watching that footage, that video footage, and watching, Miss Susan's mother being sedated, I think to an exceptional capacity. It doesn't take much for us to see that there's something flawed in that. And whether it's directives coming from a physician or an institute, or whether it's regulatory statutes and the legalities of what is right or wrong, I think what's missing is just actually viewing what is basically happening, and there's gaps. There's obviously gaps, and no matter how much you try to compartmentalize a protocol, or how much you want to tabulate or write reports, et cetera, the main issue here is that there is obviously a lot of work that needs to be done, and just adhering to definitions and trying to compartmentalize people's situations and capacities because everybody has an individual health situation. I think that there has to be something more than just directives coming. And we're missing a lot of the human factor in our treatment of individuals. And obviously, I'm just curious to see down the line research that is going to be conducted, the damage that has occurred from all these antipsychotic drugs that have been given to patients needlessly, what the end result of that is, because that is so incapacitating. And one day I would not be surprised if it will be deemed touch on criminal, because this is not, I can understand your point of view, and I can understand if you need to touch on, the subject of above aggressive behaviors, and that's another topic to be reckoned with. But it's wrong. It's very wrong the way in our medical system, the way we are treating people that are incapacitated and not mobile, and then on the other side of the coin, creating situations where healthy individuals, active individuals that have a quality of life become so incapacitated, as we have seen with Ms. Susan's mother, that it's a complete different flip of the page. Thank you.
OK. Alors, en tant que futur étudiant en éducation spécialisée, vous avez abordé le sujet des micro-units, que je trouve qui est quand même intéressant. Mais je voulais savoir où en est la place pour les éducateurs spécialisés. Parce que comme la mère de Susan et tant d'autres, il faut vraiment connaître la personne. Et ces comportements dits agressifs, même il faut changer ça culturellement. Ça peut être responsive behavior, même la façon comment on parle, ça impacte la façon comment on pense, puis la façon comment on agit. Fait que c'est bien beau esthétiquement que c'est aménagé et c'est réduit, mais qui va les divertir durant la journée justement pour pas qu'on les appelle des wanderers? Alors, est-ce qu'il va y avoir plus d'éducatrices spécialisées ou de telles sur on the unit?
Right now in long-term care facilities, you do have a therapist that there's different CHSLD, you have either a loisir, somebody that does activities, or you have educational therapists that are often part of the team.
Ouais.
This is a good question, and how many per, this is a very...
Fait que c'est ça ma question,
Yes,
parce que je fais mon stage, je sais qu'il y en a.
It's a very good question, and I'm not here to answer how many they will put per unit. I have no idea. But right now, it's like there's a need, and they're part of a team. That's what I've seen so
Fait
far.
que c'est ça ma suggestion, peut-être quand on est en train de réviser le budget ou le faire, de prendre ça en considération, parce que ça, c'est les travailleurs qui sont comme frontline, qui connaissent la personne un peu comme the best friends approach. C'est toi qui connais qu'est-ce que la personne aime avec la famille, c'est toi qui sais ce qu'il aime, les moments durant la journée qui peut être plus irrité ou il peut mieux fonctionner. Fait que ça serait peut-être quelque chose à considérer.
I just want to say I absolutely agree with you, especially with somebody who has a more advanced, if you will, disease process happening. A lot of what you called, the aggressive behavior, you had to stop people from fighting each other or whatever, is because they're totally bored. Yeah. And here's the issue in all of this. Everybody's thinking, let's increase préposés, let's increase. I'm more for increasing the special care counselors, the éducatrices spécialisées, recreation, that sort of thing. Exactly, give a lot of stimulation. And quite frankly, that would make not only reduce any incidences, but also it will make the quality of life of the people better. And I would even tell you it'll make the quality of the life of staff better. And it's such a narrow view that the ministry has in terms of that. And that needs to be promoted because, the issue is always we have to have a balanced budget, right? Everybody talks about it in the healthcare system. The government, for the last few years, and believe me when I tell you I'm retired, so I don't know the true impact, only what people tell me, but it's very, very difficult on the staff. Often very difficult decisions have to be made at the highest level. And the other thing I want you to realize, a lot of people are agonizing when they make these types of decisions. And they're there, where can we do it? How can we do it? Trying to figure it out. And for me, I really, I'm there saying, if I had a recommendation, my recommendation would be micro units. I think that's great. Lots of activities. I think that's great. Collaboration. It's a dream, if you will, but it's a dream that's obtainable if we all work together. That's the way I think.
Thank you, Mona. I think we have to conclude here. Did you want
Could
to
I
add
just
something?
say one thing?
Very briefly.
I have to
Because
agree
we had
that changes have to be made.
Yes.
The very problematic is the fact that there's so many people on sick leave.
Yeah.
The poor patients have to get used to new people constantly because everybody, the program person's on sick leave, the team nurse is on sick leave, one of the head nurses is on sick leave, the ombudsman and the replacement of the ombudsman are on sick leave. I mean, this is very, very problematic. And the matter of finding replacements, you have to first list it, and then you have to see if anyone on your staff wants it. Then it's outsourced. It can take 3-4 months to find a replacement if one is even found. So I think that the fact that illness is so prevalent and people calling in sick 5 minutes before their shift, they're major problems, and it's probably because the workload is impossible.
Could be one reason. There could be other reasons. I could follow up on what you say and what we're saying, Mona. Maybe one recommendation would be more implication and more cooperation with the family and more alternatives like educators, like recreational, musical, alternative medicines introduced into the residences, the long-term residences, and maybe it will we will lower the sick leave percentage because everyone's going to be happier. But mainly, maybe we can reduce and eliminate completely, if possible, the chemical. And I retain that the chemical restraint is a great concern. It's an immense concern, and it's very, very disturbing. So I think we diminishing also, reducing the size of the units. Reducing, yeah. All right, so thank you very much for this afternoon. Thank you, Susan. Thank you, Nathalie. Thank you, everyone, and we'll see you at another time.